You've built something really amazing here in Sarasota.
The dream of putting a team together that could work seamlessly in keeping the patient as the focus of what we're trying to do.
Offering this entire palette of treatment options for thyroid nodules.
I think the success of our overall principle is collaboration. It's a group of physicians thinking of what's the best outcome for a specific patient.
Thyroid RFA, Echolaser Ablation, microwave ablation, cryoablation, thyroid arterial embolization, traditional thyroid surgery, and Scarless thyroid surgery. Am I missing anything?
No, I think you got it pretty much covered.
I can't wait to dive into all of the different treatment options, how they work, what they do for patients, both surgical and non-surgical options. Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today, I'm grateful to have two previous guests return to the podcast. I first met Dr. Ralph Tufano at a thyroid RFA training course in February 2021. At that time, he was spearheading the adoption of thyroid RFA at Johns Hopkins in Baltimore, Maryland. In the time since, he joined a very unique multidisciplinary thyroid and parathyroid specialty center in Sarasota, Florida. My other guest is his colleague, Dr. Juan Camacho, an Emory-trained interventional radiologist who I first met in January 2023. This was shortly after the addition of laser ablation to the suite of thyroid nodule treatment options now available at Sarasota Memorial. In today's discussion, we'll dive deep into this unique collaboration, discuss how their multidisciplinary approach works, learn more about each of the treatment options available at their center in Sarasota, and so much more. Dr. Tufano and Dr. Camacho, welcome back to the podcast. It's really good to see both of you again. Yeah, a lot has happened since we first met at a physician training for RFA. So you've built something really amazing here in Sarasota, which is a treatment center that's offering this entire palette, as you called it, of treatment options for thyroid nodules. And so I can't wait to dive into all of the different treatment options, how they work, what they do for patients, and the inclusion of both surgical and non-surgical options. And this list has just continued to grow over the last few years. So the list currently, correct me if I miss one, includes thyroid RFA, Echolaser Ablation, microwave ablation, cryoablation, thyroid arterial embolization, traditional thyroid surgery, and Scarless thyroid surgery. Am I missing anything?
No, I think you got it pretty much covered.
Okay. So that's an incredible number of options. And I don't know of any other treatment center in the US that's offering all of these things. So how are you able to make all of these options available?
I think it was when I met you almost 3 years ago now, the dream of putting a team together that could work seamlessly in keeping the patient as the focus of what we're trying to do, right? So it's all about like, what can we do to provide value to our patients and not be encumbered by the typical restrictions we would have if we were in a practice where we were separate or we had different interests or philosophies, or we couldn't really come together to manage our patients in a harmonious, unified way. And so I think that I'm fortunate to have great colleagues like Dr. Camacho and our endocrinology colleagues as well, working together to really educate our patients about all the options available and then trying to personalize care. I think we all enjoy trying to get the patient to a point where they feel really comfortable that they've been part of the decision-making process and that their care has been truly personalized to them. And we hear everything they have to say and all their concerns, and then we try to come up with a solution that's going to best suit them. And so that drive is really part of all of us here, and that's why we work so well together and try to figure out, okay, what can we do to help our patients? And it doesn't matter if it's surgery or if it's an ablation therapy or if it's embolization, arterial ablation. What is that patient looking for? What's going to be the best modality independent of anything else?
I think one thing that would be really helpful to the viewers is to just go through each of these procedures and just give a quick summary of how they work and what the expected outcome would be.
Well, I'll start with RFA and then I'll let Dr. Camacho really come and explain some of the other modalities. As an interventional radiologist, it's wonderful to have his enthusiasm and interest in treating patients with thyroid disease. It's just great. And he has so much experience with all these modalities across not only for the head and neck and thyroid, but other areas of the body. So that comes in very handy to help us refine these technologies moving forward. From a radio frequency standpoint for our patients out there, what we're doing essentially is while you're here with us in the office and we give you a little numbing medication in your neck, we put a needle into the thyroid nodule, and by that needle tip, we're able to generate heat by radio frequency waves, and that heat helps us to coagulate a nodule. And over time, the body comes in and helps to sort of resorb that process. And so for a benign nodule, we see some reduction in the volume by shrinkage. And then for hopefully a small cancer, if we're treating that, we are going to see that hopefully disappear. And obviously, it has to be a very select case. So I think some of the other technologies work similarly, but Dr. Camacho also has some take on, strategically what may be better when. And that's great to hear from him about.
I think the success of our program principle is collaboration. It's a group of physicians thinking of what's the best outcome for a specific patient. We don't box in patients with a specific treatment. We just present the different options and select the adequate patient to receive what we believe is probably the best therapy. Currently, we have different algorithms for both benign and malignant pathology. As Dr. Tufano was saying earlier, we select very specific patients for the treatment of thyroid cancer, and those are usually what we call the low-risk cancers. And we've set up a limit of up to 1.5 centimeters or so.
Mm-hmm.
I think that there is no real good evidence to go farther than that. You can potentially consider it on a case-to-case basis, but I think that 1.5 centimeter kind of like threshold makes sense. On the benign arena, we're offering two types of options, what we call percutaneous options and what we call endovascular options. Percutaneous options essentially include an array of technologies that come in the form of a needle that deliver either heat or cold to the thyroid tissue. So the cold technologies are called cryoablation, and the heat-based technologies are essentially three: laser, microwave, and radiofrequency, which we all have available, and we're using them in a specific setting. So we predominantly use cryoablation for recurrences of cancers or nodules that are very close to critical structures. We use laser, microwave, and radiofrequency for larger thyroid nodules. There are size limitations to use each one of these technologies. Like if we want good outcomes, we have to take into account the location and the size of the lesion. In terms of size and vascularity, which is another variable that is very important, I think that laser can be used very successfully in lesions that are under 10 to 15 mLs, which are usually around the 3 to 4 centimeter threshold size. After 4 centimeters in size, radiofrequency is for sure superior to laser in that arena. And the closer you are to 4 centimeters, radiofrequency works well. The closer you are to 8 centimeters, microwave works. Physical reason is essentially what we call heat sink effect, is that the larger the nodule is in a very vascular bed as the thyroid is, the vascular structures essentially steal heat from the needle that we're using, and the enrichment zones that we think we're obtaining are actually going to be small. So after 7-8 centimeters in size, which correlates approximately with a volume of 20 to 30 mLs, at that point, really heat transmission becomes a problem. Those are the patients that either are going to require multiple sessions from the home to have radio frequency. You're going to require to deposit a tremendous amount of energy, and that's why you have to do it in multiple sessions. Or we believe, in our group particularly, we believe that embolization or the endovascular options are the alternative. So what we're doing for very vascular lesions, toxic nodules that are greater than that 20 to 30 ml threshold, or large goiters that are extending areas that are inaccessible to ultrasound, like the subcutaneous sinus, those are the ones that we're selecting to be treated by embolization. So embolization is just a technique in which we access the arteries, either the groin or the arm. We predominantly do it through the arm. We introduce a catheter into the arteries that are supplying the thyroid, and then we inject these tiny little pellets that go into the capillaries of the thyroid. We know that the average size is about 150 to 300 micron, and those are the particles that we inject. And those are sufficient enough to block those blood vessels and to induce what we call a controlled ischemia. It's an infarct of the thyroid gland. The occlusion of the vessels is not permanent, it's actually temporary. And that temporary infarct is what leads to the loss of volume. So I think that that's probably a pretty big summary of heat-based alternative, cold-based alternatives, and why we think that endovascular therapies have a role in which patients.
Definitely. And just for any viewers watching this who want to learn more about thyroid arterial embolization, there'll be a link in the description of this video from the last interview I did with Dr. Camacho on that topic, as well as any of the previous interviews I've also done with Dr. Tufano. So with these multiple procedures that you guys are offering, how do you determine which one is the right one for a patient aside from size? Are there other variables that you have to consider?
Yeah, I think from a standpoint of location, as Dr. Camacho had just mentioned, that's another factor. And then the behavior of the nodule. And so right now, for the most part, we're talking about volume reduction of cytologically / fine needle aspiration biopsy benign nodules that we feel confident are benign behavior, especially with ultrasound, where ultrasound is done to not only look at the thyroid, but also to look at lymph nodes to make sure we have all the supportive information for a benign process, right? And so that's what we're looking at. And as Dr. Camacho said, we're starting to think about how we combine these modalities. This heat sink phenomenon issue is a real big problem. And so what we want to do is think about going ahead and devascularizing that thyroid at least as much as we can in that nodule area for that time period, and then maybe use an ablative therapy, a thermal ablation therapy, to help augment that effect. And so we're starting to do that, and we're very interested in doing some research on that as well, because we think we can do even better. As far as when we select a small cancer, and Dr. Camacho already made mention that we're very particular about this, very small size, well-located nodule. And I would say that those cancers that are papillary thyroid cancers that we would consider for the concept of active surveillance are the ones we would consider for ablation. It's really in that regard as to, a smaller needle, a more refined delivery of the energy, maybe a little bit of margination around that nodule. And so, again, it depends on, what is going to really feel most comfortable to us. And there's a little bit of an art to that as well. So I think what we really put our heads together on is when the patient comes for that particular nodule that they have, given all those things and variables that we already discussed, what's going to be the best treatment. And it's hard to capture all of that in just a discussion, but it is something that we do and work on together. And often these discussions are evolving our approach over time as we continue to move forward. Like I was talking about combining the angioembolization / arterial embolization, and then maybe a few days later doing the thermal ablation component of it to augment that. So it's very exciting to work together in this field that way and for our patients. And I'm also glad you did mention surgery, because sometimes it's really a difficult conversation, but what we have to do is be very frank with our patients. There may be a patient or two that come through to us and they're not good candidates for an ablative therapy. And we have to be very true to them and not just, just say, oh, well, let's try something. We don't want to try something if we're not confident that that's really going to work or it's the right treatment.
Right.
And unfortunately, we see people sometimes acquiesce maybe elsewhere. We don't want to do that. And so surgery does serve a purpose. It does serve a role. And if we go recommend surgery, given as much as we love to do ablative therapies, it means that you probably really need it. And so that's why I'm glad the whole team is together to discuss all of those options at all times.
Definitely. So let's just pretend I'm a patient and I'm coming to you and I'm like, I want to know which one of these procedures can I get would I see both of you together, or how does that process work for a patient?
I think it's, again, we never box people into treatment. We're trying to shift the treatment paradigms into a minimally invasive as possible, right? But within reason. I certainly have multiple opportunities in which we'd see patients together, and I say, Ralph, listen, especially on cases with candidate, I think you'd still be better off with the surgery. Or the other way around. The important thing is to have open lines of communication, understand the variables that affect their outcomes. I think a lot of people still don't necessarily understand what interventional radiology has already gone through in other parts of the body. It's just starting to grow in the United States. We understand the limitations of percutaneous ablation. We understand very well the limitations of embolization. So if there's a good common ground here, is that surgery is never off the table.
Sure.
If someone benefits from surgery, they should definitely have surgery. And within the spectrum of therapies, we take it, at least in my opinion, we take into account first the expectation of the patient. What's the expectation of the patient? That's probably the most important thing. Following the patient's expectations, then we pull out all of our armamentarium and see how we can accomplish that mission. Of course, taking into account what's available in the medical literature and what we're particularly working in our center from the research standpoint. But definitely communication is key, and managing those expectations so we can choose. Then, the science comes in and helps us choose the right modality.
As much as we would love to see every single one of these patients together, and if you came in and you were asking about all possible options, sometimes it's just not practical. But the fact that we're so dedicated to this area and treating thyroid disease in particular, these conversations that we have, they continue to evolve, and for us to continue to learn about all of the facets and details of what we do. And so Juan probably knows more about surgery than he ever cared to know, and our endocrinologists, and we probably know more about thyroid hormone actions and blocking thyroid hormone than we ever cared to know. And I know more about now the different modalities for thermal ablation and how Juan gets advantage to put the needle in the precise locations and hydrodissect. I mean, it's just really a remarkable learning environment for us to educate each other and then educate our patients, so that when they do come and they have a perspective or they have an interest in a certain area, we can help see if we can support that. And of course, I have a patient who may come in, and let's say your tumor is predominantly, or nodule is predominantly substernal, and so we're not going to be able to get a needle there, and you don't want surgery. And so why wouldn't we have Dr. Camacho talk about an arterial embolization strategy to reduce that very effectively and see how that goes? Because we don't really lose anything by doing that, especially for something that is presumed to be benign. So again, all of these thought processes enter our minds and how we can best help the patient, and these discussions happen amongst ourselves. And then, ultimately, if I see that patient, I let Dr. Camacho know, and then shortly thereafter, he's seeing that patient and discussing the particulars of what he does. So it's very nice, and it's a great way to work together. It's very enjoyable.
That's awesome. Well, the question on everyone's mind these days is insurance. Let's talk about insurance coverage for these procedures, insurance and Medicare. Where are we today? I know it's been, an uphill battle since 2018 when RFA first came on the scene. Everyone wanted insurance coverage, and we've still been kind of waiting to see about the formation of a CPT code. So tell me where we're at there.
We just submitted a survey to all the practitioners that nationally do radiofrequency ablation. Both Dr. Tufano and myself participated in that survey. We submitted it already, and we are now kind of like at the expectation of hopefully in the next few months or in the first quarter of the year, hopefully the AMA will send out the CPT code for radiofrequency ablation specific. On the laser side, company that produces the laser fibers opted for a different strategy because the way you can opt for CPT codes, it's different. I mean, and ultimately it's up to the available evidence and whoever is investing in the R&D. So that company decided to apply for a temporary code, which is a class 3 CPT code and is available for laser ablation. But at the end of the day, it's up to the insurance if they reimburse that particular CPT code. Insurances are different across the board.
Mm-hmm.
Most of them are recognizing laser code. Medicare definitely recognizes it, but it gives it a different monetary value.
Mm-hmm.
So sometimes what happens, and which is still disappointing for patients, that some of our patients have to pay whether they burn out of pocket according to what their particular insurance recognizes or what. In terms of the endovascular procedures, the endovascular procedures are fully recognized and fully reimbursed by every insurance. So, so far we have not had any issues with embolization. Embolization it's kind of like the origin for CPT code of interventional radiology is embolization. So far, knock on wood, we haven't had any issues, and we don't anticipate having any issues in the future because it's essentially what we do on a daily basis. We're investing a lot also in research, and I think that's important to say that particularly our group is investing in developing these research strategies. We're applying for grant funding, so hopefully we can continue to lead in these arenas.
So these treatment options that are non-surgical seem to start only for benign thyroid nodules, but that seems to be expanding somewhat. So could you tell us a bit about which of the procedures might be appropriate in the case of a non-benign nodule or an indeterminate nodule?
So, Jen, I think what's important to understand is we've talked about treating known papillary thyroid cancers.
Right.
And these are small cancers situated in very favorable locations within the thyroid, where one could even consider an active surveillance paradigm, much like the American Thyroid Association supports. And if a patient psychologically felt that that was something that they would want and felt comfortable watching or monitoring a small cancer, then that would be fine. And some people ask me, Dr. Tufano, I don't have a cancer, but you're telling me you're not so sure if it's benign or malignant. But why can't you treat that nodule with a thermal ablation strategy?
Mm-hmm.
It's exactly because I don't know exactly what I'm dealing with.
Right.
And it may be a benign process, but it also may be a malignancy that's more aggressive than a small, otherwise well-behaved papillary thyroid cancer that we already acknowledged that we could even monitor, but maybe you just don't feel comfortable monitoring and you want to do something proactive, but you don't want to do surgery. So you have to understand that those patients really don't qualify for an ablative procedure when they are where we're not sure of what the behavior of the nodule is.
Mm-hmm.
And so that's very important to understand. And a small thyroid cancer primary in the thyroid that we deem amenable to an ablative therapy, or even maybe a recurrent lymph node. So let's say a patient had a treatment for a thyroid cancer, and maybe it did or it didn't involve a lymph node metastasis, but we feel like that small little focus of a metastatic lymph node we can treat. We have to be able to target it with a needle and then use the energy to try to get a complete ablation. It's not good enough if I just shrink a cancer, unlike a benign nodule where we're relieving compressive symptoms. So a shrinkage is good. Maybe from a symptomatic standpoint and even cosmetically, you're like, this looks great. And even 90%, like, wow, 90%, Dr. Tufano. I had a patient come in the other day and just with a very thin, long neck, and she's like, I look back at pictures and I can't believe it. But that's not good enough for a cancer.
Right.
We got to get rid of it. If we're really going to get the effect that we need for a cancer, we're trying to ablate those cancer cells. So it truly is an ablative procedure. And I think right now we realize that, especially in Dr. Camacho's hands too, because he has a lot of experience with all these other modalities, that he can access any one of these nodules that we've just talked about, whether it's a primary in the thyroid or even a lymph node, and then he can administer the thermal energy. And I've done it too with radiofrequency ablation in particular. But are we going to be able to effectively, completely ablate it? Otherwise, why are we doing it? And that's our goal, is to try to do that. Angioembolization, he'll discuss with you as well, is just that's not geared for a small cancer because it's not a focal treatment that is specifically to that nodule per se. Now, maybe as we continue to do research and we evolve things, and maybe we'll have a delivery of some, through that catheter into that specific nodule someday to to do the job. I mean, that's why we're always so excited about what's next, what's coming down the line. And we continue to have these discussions, and we want to lead in this area and really are interested in the research opportunities with new technologies and novel treatments in this area.
I really appreciate that detailed explanation, because that's a question we get a lot, is how do I know what's the right choice for me?
Honestly, I agree 100% with Dr. Tufano. I think that it's very different when we're dealing with malignant pathology versus when we're dealing with benign pathology. And that's why when we make a decision about treatments, it's about what's the expectation of the patient.
Mm-hmm.
So when you have a benign process, we really don't need to intervene on any of these benign pathologies unless there's some particular reason why the patient feels that something must be done. The large size of these goiters can be somehow bothersome from a cosmetic standpoint of view. And that's a fair concern and a fair reason to consult a professional. But at the end of the day, we are offered minimally invasive techniques or open surgery. We want to do it for the right reasons. And those right reasons are always going to come from the patient. So that's why laying out expectations and understanding what is the problem that the patient wants to deal with when it comes to benign pathology is so important. When it comes to malignant pathology, I think you have two arenas. We have, or maybe three scenarios. We have the active surveillance small cancer patient that can offer a ablation. You have the locally recurrent cancer, either in a lymph node or in the tissues adjacent to the thyroid bed, that for whatever reason should not be operated on right now. Or from the ENT perspective, practitioner, the surgeon feels that an operation is not indicated, then I think in that locally recurrent cancer, there is definitely a role for palliative therapies. And in the third scenario, we have the palliative scenario, which is very important. I mean, people tend to forget about these things, but it's really, really important. There's big cancers or very aggressive cancers that don't have really a good surgical option. Sometimes embolization can help palliate symptoms from compression. So that's one area. And in the metastatic scenario, we can definitely use all of our armamentarium to treat metastatic disease, as we do with other metastatic diseases. For example, we can treat liver metastasis from thyroid cancer with techniques that we're talking about, with ablation or embolization. We can treat lung metastases with the techniques that we're talking about. We can treat painful bone metastases in other areas. We can stabilize vertebral bodies, hips, etc., bones that are at risk of fractures. So that's also important to consider from the medical oncology standpoint of view. And those are conversations that also happen within our group more rarely, but they do happen. So I think that those are the three scenarios in which we can be involved in the care of patients with malignancies of thyroid. When it comes to benign pathology, it's truly up to the expectation of the patient. I mean, sometimes even a 20-30% reduction of these massive goiter can be very, very significant and very, very important. So more than the number that you set as a target, it's more about symptom relief, in my opinion.
Yeah.
Sometimes, obviously, from the scientific perspective, we have to focus on a number, and we aim always to, reduce volume from like 50 to 80%, and we want to make sure that we either normalize or maintain the thyroid function tests within normal ranges, and that we improve quality of life. But I think that the most important thing is we need that feedback from the patient. That's, for example, why our research protocols are based on quality of life. When it comes to benign disease, that's the most important feedback that we have.
I agree wholeheartedly. I remember when my nodule was 75 mLs and I was looking into RFA, and I thought, if I could just get a 50% reduction on this thing, I would be ecstatic. And when I achieved that and then went well beyond that to a 90% reduction, I was absolutely floored and amazed that I was able to reduce the nodule. Well, I didn't do it, but you know what I mean.
Mm-hmm.
To have
your
that
body
amount of
helps.
reduction.
Your immune system helped.
Right. So yeah, my quality of life went through the roof in comparison to what it was before I had my ablation. So I want to talk a little bit now about the ATA guidelines that just came out and what the impact has been on these procedures being made available and the adoption of them. How has that played out with these new guidelines?
So I think, Jen, you're mentioning the ATA statement on ablative therapies, right? With RFA in particular being highlighted. And, I think a number of professional societies, and as Juan has said, interventional radiology has been doing this for a while, but then surgical societies and endocrinology societies have now started to put together consensus statements and white papers on the subject matter. And I think what it does is it puts at least a framework together for the safe adoption of these techniques and when to consider using them, as we've elucidated so far in this podcast. And so I think it makes people and practitioners and patients, whoever reads these manuscripts and this information, more aware of these options, but also provides some perspective on how to adopt these technologies and practices, and then also in which situations they can be used. So, and it does also give some credibility, right? Now that we have the different medical professional societies supporting statements on this, they're realizing how important it is and how important it is to their constituents and also to their patients. So I think that's where, now we see people getting interested in it. They see a framework for safe adoption and utilization and providing perspective on who should undergo it and when. And we need that because when you do have a new technology and so many people are starting to use it, obviously there's different levels of skill from an operator standpoint, and then also the understanding of when to apply it. So we need to provide a really sound framework and understanding.
I agree wholeheartedly. I think that it was really encouraging to see the number of participants at the ATA meeting training that you were a part of this year, Dr. Tufano. So many physicians attended that training and were wanting to learn about all these different modalities. And I'm just hopeful that as time continues to pass, that as you go to your various meetings that you are a part of, different organizations, that you see more interest, but also, as you were saying, Dr. Tufano, that it's a safe adoption and, that the patients are going to have skilled providers in the end. So with the increasing of the physicians that are now doing these different procedures, we've also seen a huge increase in the number of patients in our Save Your Thyroid community. So at the time when I first met you, Dr. Tufano, there were 2,000 patients in our community, and I thought that was amazing. Well, now we literally are one person away from 9,000. And
Wow.
It's only been
Congratulations.
thank you. It's only been just a short time. I started the group in the summer of 2019. So this is just one of the testaments of how much patients are excited about the possibility of being able to preserve their thyroid. One thing that you said, Dr. Tufano, at the ATA meeting that I thought was so great was you said to the physicians who were in attendance that they needed to be prepared. These patients' appointments, when they are members of Save Your Thyroid, their appointments take longer.
Yeah.
And
that was in a good way because they're educated and
yeah,
they've done their research and they've heard about options that don't necessarily make sense to them. And then they want to know about this option and why it should make sense because it sounds interesting and it sounds like it should work. And is it for me? And so you have to know your stuff. If you
yeah,
don't know your stuff and you don't understand all of the aspects that are involved with managing patients with thyroid disease, then you're not going to be able to inform them. They're coming in, they already have an excellent level of understanding, but they want that extra information to help them make a decision. Is this right for me? Is this an option for me? What is the value proposition for me? That's very, very important. One of the things I say is that, I hope the community, by those white papers and the consensus statements that you heard about just before we were talking about, becomes more informed, because sometimes you still see, even they've seen a practitioner locally and they've been dismissive of an intervention other than surgery. And we can't have that paternalism really in the management of patients. We really have to think beyond just what we can do, understand what everybody is doing in the field, where the field is going, and then provide, a balanced discussion for the patient. And if you don't do the procedure and you don't understand enough about it, there are experts out there. There is Save Your Thyroid, where there are resources to avail yourself of and get this information and get informed. A patient should never be treated in a dismissive way and saying, I don't want to hear about that. I don't want to talk about that. You need surgery.
Thanks so much for watching this episode. I hope you're enjoying it. This podcast requires a lot of my time, effort, and resources, but it is a labor of love. If you'd like to directly support my work here, you can do so in 2 different ways. You can purchase products from one of my affiliate brands, or if you would prefer to make a donation directly to the podcast, you can do that as well. Links to do either are located in the description below. Every dollar contributed goes right back into this podcast. Additionally, if you'd like to support the Save Your Thyroid patient advocacy community, which is working toward becoming a nonprofit organization, you can donate via our fiscal sponsor, THYCA, Thyroid Cancer Survivors Association. Simply visit thyca.org, click donate, and designate your gift for SYT. To learn more about us and the work we do, please visit saveyourthyroid.org. If you have any questions about any of this, don't hesitate to email me at saveyourthyroid@gmail.com. Any way you choose to support the podcast or the SYT community is sincerely appreciated. Your generous contribution keeps this work going and helps us to help more patients like me and you. Thank you so much for watching, and now back to the podcast.
One of the important things then is to make sure when these patients come in, they want to know, why do I need surgery, and why wouldn't I be a candidate for one of these other options? And if you don't understand these other options, if you don't read about them, even if you don't perform them, you're not going to be able to inform the patient. So the patient can avail themselves of this information by seeking expertise, which exists in a center like ours, for example, or even Save Your Thyroid, which helps to guide them at least with some of the basic information, and then helps to support them in finding experts who can talk about it a little bit more in detail. So I think that's important to foster that support and their enthusiasm to find out more information.
At the beginning of this conversation, also Dr. Tufano kind of emphasized something that I want to really bring up again, and is the power of educating ourselves as colleagues. That's very, very important, because when you have an uneducated doctor about a certain procedure, as Dr. Tufano was saying, they tend to be dismissive. And we, not only our center as a group, but in general, our community, people that are working in minimally invasive treatments for the thyroid, we have a big mission ahead of us, which is also educate and train our own colleagues that are not necessarily familiar with what we can do. This is something that has not happened only in this arena. Interventional radiologists were very tolerant to frustration, trust me. We've learned we're a new specialty, and we've learned over the years of how to overcome these barriers, because we've been doing this for a long time, and it's really, as I said multiple times to Dr. Tufano, the success of programs like this is the ability to create education about different specialties and to embrace multidisciplinary cooperation without having, reimbursement or RVUs or egos fighting for you. Because when that happens, and that's just not conducive to good patient care. And as an interventional radiologist that has had interactions like these with urologists, because we work in the same arena with urologists, or with gynecologists, or with general surgeons, or surgical oncologists, or thoracic oncologists. So we have learned that the best way of moving forward is by having this multidisciplinary collaboration. So if there's a message that could transmit to the people that are seeing this, is that it is extremely important that whenever you have a problem with your thyroid specifically, you should consult multiple different specialties that actually know about this type of problems. Because that's how you're going to be able to build up knowledge about your disease. You're actually going to be helped to make the right decision for your particular problem.
Absolutely. I agree. And is there anything that either of you, after you've interacted with so many patients from our community over the last few years, is there anything that you could see that maybe we could do differently or do better to help patients as we move forward?
They are really clamoring for more education and more information. I think it's important to highlight patient experiences. And much like we've been talking about today, in a very collaborative manner, where again, they've had all of their options discussed, and these centers do exist, and to be able to speak to them and provide those resources as they're available for them. It's hard when there's so much out there and there's so many people who are starting to do it, and where to go, and should I travel, or can I find somebody locally? And it's challenging. It's a lot of information, and I think patient reviews are really important. Patients who have already been through the process, much like yourself and others, what their experiences have been like, what their expectations were, and if they were met, and if they weren't met, were they still okay? Did they have unreasonable expectations? And then ultimately, what was the outcome, and what did they think about the whole process? Because I think it's very challenging to navigate this area for a patient and really understand where they may be best served to get this information. Letting people speak, like that forum, having patients who have been through this to give their story, to give their impressions, and in a very unbiased manner. That is probably the most important thing that you can do and continue to do. I know you guys do that, is to share in that, because that's truly honest and unbiased feedback, So it's nice to have that. And I would continue to develop that part of Save Your Thyroid, because that's really critical.
I appreciate that feedback, Dr. Tufano. And where do you see the future taking us with all of these different treatment options?
Particularly, I'm very excited because I feel that there are a lot of avenues that we haven't explored yet. The toxic nodule and toxic multinodular avoiders, it's something that we really need to dive in. I think that will be really impactful because it's not only about the compressive symptoms, but also the hormonal manifestations of those. And right now, those patients that have not in process ultimately standard of care, at least right now, it's thyroidectomy. So I think that exploring these different or alternative solutions in such population is going to be impactful. Extrapolating from the interventional radiology experience, we have a gigantic drug delivery platform, and I think that in the future, hopefully we can take advantage of that experience to deliver both anti-cancer medications and radiation therapy directly to the thyroid from the intravascular perspective. I think directly from the blood vessels, directly into the thyroid. And I think that that's something that it's going to be interesting to explore. And there's other technologies that provide non-thermal ablation, and like pulse electric fields or universal electroporation. I think that different companies that are exploring this and they're used in benign and malignant thyroid pathology. So that's going to be exciting because I think that the next 5 to 10 years there's going to be boom in these therapies. We can't forget that there's around 100,000 thyroidectomies in the U.S. per year. I think that that's a huge number, and that's probably an underestimated number. And many of these thyroidectomies are for these processes. 50% are for toxic nodules. 50% are approximate for non-toxic nodules. So it's something that it's definitely has the capacity and the ability to impact a huge chunk of the population from outside.
Yeah, I am too. I think when we look back 10 years from now, we're going to look at it and say, wow, what we were doing back then, it was pretty basic. Look how far the field has come, right? Because there's so many opportunities with automation, image guidance, conforming energy and different types of energy, maybe having smarter instruments, right, at the working tip, or whatever you're using, having an interrogation of the tissue as you go to tell you what has been ablated and what hasn't. I mean, we call it like a smart technology. It's really incredibly exciting to think where we're going to be in 10 years. And I think that this is really here to stay. It will continue to evolve, and we will probably see less surgery done in this area and maybe in a lot of other areas of the body. And hopefully that will result in an overall better quality for patients across the board. And I'm really excited about the future for all of these techniques and how it will evolve. And being part of it is really the motivating factor and a lot of fun.
Well, I appreciate you both so much. All of the work you're doing, it's amazing. And it's just been a pleasure getting to know both of you. I look forward to the next time I get to interact with you in person, hopefully sooner rather than later. But thank you so much for taking the time, both of you, today. Can't wait to see where the future takes us. Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community. Save your thyroid. You can also find me on social media and Substack under the media handle It's Me Again. Never forget to educate yourself and be your own advocate and save your thyroid.